let's have an interactive session. So please unmute your mics. Let's discuss.
Oh my God. No, like,
Okay, so question 16 is a question on copper IUCD. It says, how does a copper IUCD prevent pregnancy? A, by releasing hormones that suppress ovulation. B, by thickening the cervical mucus, making it difficult for sperm to enter the uterus. C, by creating a physical barrier that prevents fertilization of the egg. D, by disrupting the implantation of a fertilized egg in the uterus. So what do you think? What do you think is the mechanism of action of a copper IUCD? Yes. Any attempt? Any idea?
please.
Are you able to unmute yourselves?
I think maybe by thickening the cervical mucus, making it difficult for sperm to enter the uterus.
Fair enough. Does anyone has any other answer?
Disrupting the implantation of a fertilized egg in the uterus.
More attempts. So far, we have someone with B, we have someone with D.
By releasing the hormones that suppress ovulation.
Okay, this is a little bit of a tricky question because it has a primary mechanism of action and then it has a secondary mechanism of action. So the primary mechanism of action is actually preventing fertilization of the egg entirely because it causes some chemical reactions within the uterine cavity that disrupts the sperm. So fertilization does not even occur. That is the main primary mechanism of action of a copper IUCD. But then some researches have also shown that copper IUCD can interrupt implantation, but then that is not its main primary mechanism of action. So the answer here is C, by creating a physical barrier that prevents fertilization. Fertilization entirely does not even happen. But then if the fertilization cyst happens, then it will disrupt the implantation of the fertilized egg. So the next question, how long can a copper IUCD remain in the uterus before it needs to be replaced? 1 year, 3 years, 5 years, 10 years. How long do you think it stays? How long does it last?
10 years.
5 years?
10.
Yes, it can last 10 years before it needs to be replaced. It's a long-term contraceptive. So it lasts for 10 years. Then this question says, which of the following statements is true regarding the effectiveness of copper IUCDs? A, copper IUCDs are 100% effective in preventing pregnancy. B, the effectiveness of copper IUCDs depends on the woman's age and fertility. C, copper IUCDs are less effective compared to hormonal contraceptive methods. D, copper IUCDs are only effective for women who have given birth. So, what do you think is the answer? Let's interact. Let's be fast so that we can be able to answer as much questions as possible.
I think
Effectiveness of the
C.
copper is okay.
You think which option?
C.
Okay, then the other one that was speaking after you.
B.
So you think they are less effective than the hormonal contraceptive methods?
No, I
Yes.
think the effectiveness of the copper IUCD depends on the stage and fertility.
So you are thinking B.
Yes.
So let's analyze. Is there any contraceptive method that is 100% effective?
No.
No.
So we know A is out of the way. B, yes, you can consider D. Because different people, what work for this woman might not work for the other woman. And then the age and the fertility also plays a role. Then C, copper IUCDs are less effective compared to hormonal contraceptive methods. They actually have the least failure rate, copper IUCDs. So they are more effective than the hormonal contraceptive methods, and they tend to have less side effects than the hormonal contraceptive methods, and they tend to be more accepted by women because you don't have to be like when you insert it once, it's just when you go for removal that you have to do anything to handle it. Compared to other drugs, injectables or implants, that injectables you have to be going either monthly or 3 monthly to be getting injections. So C is not correct. Then D says copper IUCDs are only effective for women who have given birth. Obviously, this is not true. Even nulliparous women can use copper IUCDs and they are effective in them as well. So the correct answer here is B. Then this question says, write a clinical condition where each of the drugs are used. Basically, we have A and B. So the answer has already been written. A is hydralazine. And hydralazine injection is commonly used for the management of severe hypertension. Like in preeclampsia, you can give, or gestational hypertension when the VP is very high and you want it to come down, so you can give IV hydralazine. And then the second picture is ergometrine, which is an injection, also known as ergonovine, and is primarily used in the prevention of postpartum hemorrhage. It causes uterine contraction and prevents uterine atony. So this answer has already been written. And then we come to patograph. So what is the primary purpose of using a patograph during labor? A, to monitor fetal heart rate. B, to assess cervical dilatation. To track maternal vital signs. D, to ensure timely intervention during labor. So which of this is a primary purpose of the patograph?
D. To ensure timely intervention during labor.
Yes, so the main purpose, all of these are purposes of the patograph, but the main purpose of why patograph was even invented is to ensure timely intervention during labor. So D is the correct answer here. We will have a session to go through patograph. Then question 21, what information does a patograph provide to healthcare providers during labor? A, progress of cervical dilatation and descent of the baby's head, true or false?
True. True.
Okay. B, maternal blood pressure and heart rate measurement. Is this true or false?
True.
True.
Then C says fetal heart rate patterns and variability.
True.
D. Administration of pain relief medications.
False.
It's actually true. If you look at this, there is a column for
There's a
drugs and
section
IV
for
fluids
drugs.
given. So you can as well document the administration of pain relief. Is that clear? Is it clear?
So what is the answer?
All of these options are true
Okay. There's no
because it provides all of this during labor. So you can't say one of the options is wrong because
Okay.
there is no wrong option here. All of this can be plotted on the pathograph.
Yeah, but there's no option that says all of the above. So how do you go about it during the exams?
Yes. So obviously, I think there should have been an E option that says all of the above.
Okay.
Question 22. What is the recommended action if the progress of cervical dilatation on the pathograph crosses the alert line? A. Administer oxytocin to stimulate uterine contractions. B. Prepare for immediate cesarean section. C. Wait for further observation and reassess in 1 hour. D. Begin preparing for an assisted vaginal delivery. So what do you think is the odd answer here?
D?
Sorry,
What do you think is the odd answer here?
prepare for
Mhm.
immediate cesarean section because it's just on the alert line. It's not showing any obstruction yet.
Okay. Who else has another option? By the way, just in case, this is the alert line that we are talking about, and then the actual line. So what do you think should happen?
But I
Someone
think
has
you
already
asked for
said
the
D.
wrong answer, right?
No, what will be your next action?
Oh,
What will
okay,
be
administer oxytocin.
at the alert line? So
C.
are
Wait for
you
further
to
observation.
administer oxytocin? She's just on the alert line, not the actual line. Remember.
Yeah, but
Yeah,
I
you
heard
wait.
you still administer it regardless, just because you don't want to wait for a problem to occur before you stimulate the contractions.
But for a woman to be on the alert line, yeah, you have to be alerted, but then it is not time for you yet to take action.
Okay, so you just monitor.
Yeah, so you wait for further observation, and then instead of waiting to reassess her after 4 hours, you reassess in 1 hour and see how it's going.
Okay.
Then question 23, what is the primary purpose of using magnesium sulfate injection in medical practice? A, treatment of bacterial infections. B, prevention of blood clots. C, management of preeclampsia and eclampsia. And then D, relief of severe pain. So what's the
Management of
answer here?
preeclampsia.
Yes.
C.
Yes. Next question says, what is the primary purpose of using magnesium sulfate injection? Okay. Well, it's the same question actually. Coming again. All right. How does magnesium sulfate injection act in the management of preeclampsia and eclampsia? A, by reducing blood pressure and preventing seizures. B, by promoting uterine contractions and inducing labor. C, by increasing blood flow to the placenta. D, by inhibiting premature labor. So what do you think is the answer here?
A?
Reducing blood pressure and preventing seizures.
I'm not sure.
But what is the main mechanism of causing the high blood pressure?
It acts by increasing the blood flow to the placenta.
Yeah, so your A is correct. Why is it it's just like two people just interacting? A is actually the correct answer. It helps in reducing the blood pressure and preventing seizures.
Okay.
So question 26 says, a 21 years old unmarried girl presents to your clinic after having unprotected sex last night. What methods can you use in this patient as postcoital contraceptive methods? Please give me 5 minutes. I'm coming.
Okay.
All right, let's continue. Question 26 says, a 21 years old unmarried girl presents to your clinic after having unprotected sex last night. What methods can you use in this patient as postcoital contraceptive methods? So we talked about emergency contraception in a question previously. So which of these drugs can you use? OCP, oral contraceptive pills, that is 1. Then 2 is prostino, which is levonorgestrel. Then C is Depo-Provera. And 4 is IUCD. So which of this can you use as an emergency contraceptive?
Postino.
3.
3.
Copper. 3. Copper 4.
Yes,
Emergency.
you can use copper. You can use copper. Copper IUCD can actually be used up to 5 days.
Okay.
So you can use copper, you can use postino as well.
Okay, no, no.
That's 2 and 4.
Yeah.
Then B says a 35 years old healthy woman with 2 children, aged 3 and 5, requests an emergency contraceptive after unplanned coitus 4 days ago. Name a method that you will offer to this woman. So the most effective one that you will give her is copper IUCD. Because an unplanned coitus of up to 5 days can be prevented. A pregnancy can be prevented by a copper IUCD.
Okay.
So 4 is the correct option. Then we have 27. There's a picture of a quadrivalent human papillomavirus vaccine. It says identify the specimen. So what is the specimen? I've already mentioned.
Gardasil.
Yeah, it's Gardasil quadrivalent form. What and then B says, what specifically is it used for? Well, it is yes, go ahead.
No,
It has already been written. You can actually read the answer from the slide.
okay. Yeah, it's a recombinant vaccine against human papillomavirus.
So the quadrivalent human papillomavirus recombinant vaccine is primarily used for prevention of certain types. It is used for prevention of certain types of HPV infections. And then it is effective against types 6, 11, 16, and 18. Then C option says, list the virus strains it protects against. The beautiful thing about picture test is sometimes the answers for your question is actually on the picture displayed. So if you look at the vial, it has already been written types 6, 11, 16, and 18. So in each picture test, just look carefully. The answer might actually be on that picture. So you don't have to be thinking, okay, what is the answer? Can I remember? Especially the sizes of NG tubes, cannulas, if you get them on any station, just look at it. The answer is there.
Okay.
The answer is written there. So you don't have to go very far looking for it. And then question 28 says, identify the instrument. So what is this instrument?
Forceps.
Yes, it is a delivery force app. Then B says, mention 2 indications for its use.
Maternal exhaustion, fetal exhaustion.
Yes. Prolonged second stage of labor, fetal distress, fetal impaction. Then mention 4 prerequisites for the obstetric use of a forceps. What must be there before you can use a forceps for assisted delivery?
Full
Fully
cervical
dilated.
dilatation.
Yes.
Oxford has to be anterior.
Yes.
There has to be a rupture of membrane.
Yes. So some have been written here. There's actually a mnemonic forceps. So there should be full cervical there should be full cervical dilatation. The os has to be opened. There should be rupture of membranes. There should be adequate analgesia. And then, of course, you need to have a skilled healthcare provider. Then C says, mention complications that can occur. So what other complications can occur apart from the ones that have been written? Maternal trauma can occur. You can cause fetal injuries, clavicular fractures, brachial pulses. There can be an increased risk of operative vaginal delivery. Can you think of any other complication that might occur?
Maybe infection.
Yeah, you can introduce infection if the instrument is not sterilized. Then, okay, this is the last one here. What is the type of breach shown here?
Complete breach.
What is the type of breach? Sorry, I didn't get you.
Complete
Yeah.
breach.
Yes, it's a complete breach. What are two common complications that can occur if this woman is allowed to deliver? If this woman is allowed to deliver vaginally?
Maternal injury,
Can you be more audible? So what are complications of breech delivery?
palsy, arrest of the
Yes,
fetal head, fracture of the femur,
so there can be fetal head entrapment. You can cause intracranial hemorrhage because of the rapid compression of the head during the delivery. And then birth asphyxia can occur. There can be cord accidents. And then to the mother, it can cause genital tract injuries. And then you put her at an increased risk of having a cesarean section. There can be failed breech extraction. So you might have to take her for cesarean section. Then question 3 says, what can you offer the patient if you see her in the 36th week of pregnancy?
external cephalic vacuum,
What did you say?
external cephalic vacuum,
Yes, you can offer her external cephalic version, but you know, for external cephalic version, the woman has to be prepared. You don't do it bedside most of the time because you might have to rush her for emergency cesarean section. Yes, so you can offer her the option of external cephalic version, and then you can offer her the option for elective cesarean section
cesarean section.
or breech extraction, breech delivery. So this is all for the MCQs. Let's for the picture test, we can continue with the MCQs, I think. I'm sorry about that. So let's continue. I think we stopped on question 51. So question 51 says ovulation induction results in multiple follicles development. What hormone is responsible for this multifollicular development? A. FSH, B. LH, C. Prolactin, D. Growth hormone. So what is the answer? What do you think is the answer? What is responsible for follicular maturation? Follicular development. Which of these hormones?
LH.
Is LH responsible for follicular maturation or for ovulation?
Ovulation. Sorry.
FSH.
Yes. So sometimes you might be in a hurry to answer the question because if you are not 100%, just read it twice, come back again, and then because sometimes you might be, oh, this is it, but then you might have read a different question in your mind. So FSH is the correct answer. LH is for ovulation. 52 says
Exactly what I did.
Yeah. Yes. Question 52. A 28-year-old gravida 2 + 0 + 1 presented with complaints of severe abdominal pain of 6 hours duration and vaginal spotting for 1 week. Her LMP was 5 weeks ago. The management of this patient should include. So first of all, with this her presenting symptoms, what comes to your mind? She's having severe abdominal pain, vaginal spotting, and then her last menstrual period was 5 weeks ago. What comes to your mind?
Ectopic pregnancy?
Of course, you should be thinking ectopic pregnancy. So in the management of this patient, what will be included? A pelvic ultrasound scan, B, laparoscopy, C, methotrexate, D, laparotomy. So which one will be included in her management?
All?
Is it an ultrasound, laparoscopy, or laparotomy, or methotrexate?
Okay.
Yeah. So of course, you have to even confirm the diagnosis of the ectopic pregnancy before you go ahead to decide whether you are opening her for a laparotomy or a laparoscopy, or you are doing conservative management with methotrexate. So A is the correct answer. Question 53 says ectopic pregnancy can be associated with A, congenital tubal anomaly, B, prior PID, C, IUCD, D, all of the above. Which of the following increases the risk of having an ectopic pregnancy?
All of the above.
Yes, all of the above can increase her risk of having an ectopic pregnancy. Question 54 says, the life-threatening complication of septic abortion includes A, peritonitis, B, renal failure, C, none of the above, D, all of the above. So what is the answer? What do you think is the correct answer? Can septic abortion lead to peritonitis?
No.
Really, you don't think it can lead to peritonitis?
It can.
It can lead to peritonitis.
Mm.
And then can it result in renal failure?
Yeah.
Yes, it can. You can have MODS. So renal failure can occur. Then, so is it none of the above or all of the above?
All of the above.
Yes. Question 55. Regarding to shoulder dystocia, A is defined as a period 30 seconds or more between delivery of the head and the shoulders. B, it requires use of additional maneuvers other than downward traction on the fetal head to deliver the shoulders. C, most cases can be predicted. D, results in brachial plexus injury. So let's analyze the options one by one. Is it defined as a period? What is shoulder dystocia? Is it defined as a period 30 seconds or more between delivery of head and the shoulder?
No.
Is this correct? So what is the right definition? The right definition is failure of spontaneous delivery of the shoulder after the head has been delivered without it requires additional maneuvers to deliver the shoulders. So that is the definition. So A is not correct. Then B says it requires use of additional maneuvers other than downward traction. Of course, this is true. Then C, most of these cases can be predicted. Yes, you can predict when you are expecting for it might be a difficult labor. So you are expecting you will have it might be a macrosomic baby. So of course you can predict, okay, we might be expecting shoulder dystocia to occur. And then D results in brachial plexus injury. Yeah. So the only wrong answer here is A. And therefore A is the answer.
Okay.
Complete of a gestation. A, respiratory distress syndrome. B, electrolyte disturbances. C, hypobilirubinemia. D, all of the above. So what do you think is the correct answer?
D, all of the above.
Yes, all of the above can occur as a complication of poorly controlled GDM. 57, primary postpartum hemorrhage. A, occurs within first 24 hours of delivery. True or false?
True.
True.
Then B, it can be due to uterine atony.
True.
Is it true or false?
True.
Then C, ergometrin should be avoided in hypertensive patients.
True.
So all of the above are true. All are true regarding primary postpartum hemorrhage. Question 58. Which of the following describes sickle cell disease? It is an autosomal dominant disorder. Is it autosomal dominant?
No.
No.
No. Recessive.
Yes. Then B, hemoglobin SC, they have SC genotype. Is it
No.
SC?
No, SS.
No.
What?
No.
Yes. HPLC is used for diagnosis. What is used for the diagnosis of sickle cell?
Electrophoresis.
Yes. Then D, patients are at risk of preterm labor. Are sickle cell patients at risk of having preterm labor? Of course, they are at risk of
Yes.
having preterm labor. So D is the correct answer. #59. Causes of anemia in pregnancy. A. Iron deficiency. B. Sickle cell anemia. C. Autoimmune hemolysis. D. Acute blood loss. Which of this is a cause of anemia in pregnancy?
A.
Iron deficiency.
But
Or
will
D.
sickle cell anemia cause anemia? Yes, D is actually the odd option because iron deficiency will cause anemia. Sickle cell, they will have anemia. Autoimmune hemolysis, they can have anemia. But then pregnancy is not characterized by acute blood loss. So D is the odd option here. #60. The target indicative of good glycemic control for diabetes in pregnancy include a fasting blood sugar of 8 millimoles per liter. Is this indicative of good glycemic control?
No.
A 2-hour postprandial sugar of 11.1. Postprandial, yes, you can have it within this range. She just ate. Then C, random blood sugar of 4 to 9 millimoles per liter. What do you think? Then this is weight loss of 5 kg above pre-treatment level, if above 90 kg.
Yes.
So you are telling the pregnant woman to do it. Is it 90 kg or 100? So basically the correct option, the only thing here is B. B is the right answer. Question 61. Abdominal hysterectomy has the following advantages over vaginal hysterectomy. A. It causes less postoperative pain. True or false? Abdominal versus vaginal. Which one has less operative pain? Abdominal hysterectomy or vaginal hysterectomy?
Vaginal, right?
Yes, vaginal has less operative pain. Then B, the ovaries may be removed more easily if an unexpected endometrial cancer is discovered. If you are doing a vaginal, if you are doing an abdominal hysterectomy, and then you discover an unexpected endometrial cancer, is it easier for you to remove the ovaries or during vaginal hysterectomy? Which one will be easier?
During abdominal?
Yes, so this is true. It will be easier. Then C, a large uterus is usually removed. Yes, a larger uterus is removed via abdominal hysterectomy, while the smaller one is removed via vaginal hysterectomy. Then D, prolapse can be repaired more adequately by placating the uterosacral ligaments. That is also true. But then E, postoperative recovery is more rapid. Is it more rapid with abdominal or with vaginal?
Vagina.
Vaginal, right?
Yes, it is more rapid with vaginal. So option A is false, B is true, C is also true, D is true, and E is false. So you can't really pinpoint one answer and say this is the correct answer. Then question 62. The following is or are to be factors associated with poor prognosis of endometrial adenocarcinoma. So which one is a poor prognostic factor here? Hormone receptor positive tumors, B, grade 3 tumors, C, aneuploid tumor, D, papillary serous adenocarcinoma. So which one has the worst prognosis here? So for a tumor to be hormone receptor positive, is that a good thing or a bad thing?
That's a good thing.
Good thing, right?
Yeah, it's a good thing. So you are taking it out. So basically in endometrial adenocarcinoma, grade 3 tumors have the worst prognosis compared to all other tumors. They have the worst prognosis. So grade 3 tumor is the one with the worst prognosis. Sixty-three, screening and prevention of preeclampsia. A, uterine artery Doppler assessment. I think we have answered this question previously, right? It seems more like a repeat question. We've answered it, right?
Yes.
In the first half of MCQs.
Yes, it's answered.
Yes. Management of preeclampsia, which is incorrect. A, serum uric acid value of 360 millimoles per liter at 28 weeks of gestation should be recognized as abnormal. B, uncontrolled BP is when the BP cannot be controlled with maximum dose of 3 first antihypertensive drugs. Vomiting can be an indication of severe disease. The clotting profile should be done in all cases. So which of these options do you think is incorrect? Of course, you should do clotting profile for all patients with preeclampsia to have a baseline. So we know D is correct. Vomiting can be an indication for severe disease. That is also correct. Uncontrollable BP. You say the BP is uncontrollable when you have given her a maximum of 3 doses of antihypertensives. That is also correct. So the only option that is not correct here is A. '65 indications for delivery in patients with preeclampsia except A, term gestation, B, IUGR, C, pulmonary edema, D, none of the above. So which of these is not an indication for for delivery? Is term gestation an indication?
Yes.
Yes.
IUGR,
Yes.
Yes.
pulmonary edema.
Yes.
So none of the above is the answer because all of the options are indications for delivery. So D is the answer. Question 66. The following protect against uterine fibroids except A, pregnancy. Is pregnancy protective against uterine fibroids?
Yes.
Smoking. Yes. Exercise.
Yes.
Diet rich in fat.
No.
Of course, obesity is a risk factor for fibroids, so D is the answer. And then 67, the following are complication of uterine fibroid. A, degenerative changes. B, uterine inertia. C, obstructed labor. D, all of the above. So what do you think is the correct answer?
All of the above.
Yes, all of the above can be complications of uterine fibroid. Question 68. Regarding the abortion law. A, it is permitted to save life of the woman. True or false? True. Then B, the criminal code law is in effect in the southern part of the world.
True.
C, penal code law is in effect in the northern Nigeria.
False.
Why do you think it's false? It's false. So that means abortion is legal in the northern part of Nigeria.
Not that it's legal, but
No.
nobody is monitoring. Okay, it's
Is it legal? Did I hear you say it's
no,
legal?
it's not legal. It's false.
So that means C is also correct.
Yes.
Because if actually in exam, it doesn't matter. You know that it is illegal. Even if everyone is doing it, in the code of law, it says it is illegal. So in exam, stick to what is being said in the book. It might be done everywhere, but then D says it is illegal in most parts of the developed world. Many countries have legalized. Yes. Yes, many of these developed countries have legalized abortion. So D is the correct answer here. It is the only answer that is false. Then 69, components of post-abortal care does not include A, emphatic counseling of the patient. True or false? Is emphatic counseling part of post-abortal care?
True.
Yes, you
Yes.
emphatically counsel with the patient. So it is a part of post-abortal care. B, emergency treatment of incomplete abortion and potential life-threatening conditions.
True.
Then C, family planning services. Then D says distribution of condoms. So which one of this is not a part of the post-abortal care?
D.
D.
Yes, of course, you empathize with the patient, you counsel, you tell her it is something that is not going to, it's something that is less likely to happen again. And then you figure you help, you then evaluate and see what was the cause of the miscarriage. Then you complete an incomplete abortion and you manage any complications that she's likely to have. And then you explain family planning services to her. You explain to her that she should at least rest for like six months to a year before she takes in again. Then, of course, you don't go about distributing condoms to women who have had miscarriage, because these women, after they have a miscarriage, they want to take in again as soon as possible. So that's why you have to advise them on having family planning services, because the cause of the miscarriage might not have subsided. So if she takes in as soon as she miscarried the other one, she might miscarry again. But if she gets some time, she gets evaluated, and the cause of the miscarriage is being figured out and managed appropriately, then she can get pregnant again. So D is the correct answer here. Then question 70, concerning habitual abortion. A, cervical cyclage is not always successful. B, karyotyping is a preventive measure. C, it leads to divorce mostly. 3 or more consecutive spontaneous pregnancy losses after age of viability. So what is habitual abortion? Let's start from there.
3 or more consecutive spontaneous pregnancy loss before the age of viability.
Yes. So
With the
automatically, you have ruled out option D, because D says after age of viability.
Yes.
It is before age of viability. So D is a wrong option. Is it in all cases that cervical cyclage is not successful?
No. Only in cervical insufficiency.
Yes. Karyotyping is
No.
a preventive measure. The babies might be having one congenital anomaly. So if you karyotype, is it a way of preventing? For example, if you do in vitro fertilization and then transfer, you know the karyotype of the baby. Is it a way of preventing the habitual abortion?
No.
Of course you can. Let's say, now with development and everything, during IVF and stuffs like this, you can be able to choose the gender, the genetic makeup, and everything. Like for people who have family history of congenital disease, congenital anomalies, they get to do IVF, figure out, okay, is this zygote going to have this congenital anomaly? If that zygote is found to be, of course, we don't do it in Nigeria, but it is being done in developed countries. So it's kind of a way of preventing these habitual abortions. If you do it via IVF, baby is found to be having, you can decide, okay, we are not going to transfer this fetus into the mother, because even if we transfer it, she's going to have a miscarriage. Do you understand what I mean? It is not done in Nigeria, but developed countries, they do it. See, it leads to divorce mostly. Does it?
Yes.
So D is the odd option here. Is the option that is not correct. So 71, regarding silent abortion. A, it is also referred to as early fetal demise. True or false?
True.
B, treatment is invariably by evacuation.
True. No.
Really, do you evacuate a missed abortion, a missed miscarriage?
No.
In missed miscarriage, the woman will just come to you that all the symptoms of pregnancy that she was having initially seem to have faded away. She's not having those symptoms again. And then only for you to do an ultrasound scan, you see an empty uterus. The woman has miscarried without her even knowing that she had miscarried that pregnancy. So you don't need to evacuate. Then C, the uterine size always agrees. What do you think? Is it true or false? Does the uterine size agrees with the date?
Yes,
False.
Of course, it's false.
it
For
agrees.
her to have, it does not agree with the date. She might, for example, she might be 23, she might be at 23 weeks gestational age. She doesn't know that she has had a miscarriage. She'll just come to you, doctor, I am at 23 weeks or maybe 25 weeks, but my stomach does not seem to be growing. So does this statement agree with each other? She's telling you she's 25 weeks. But of the uterus. So of course, does agree with the hospital. So do you have to hospitalize this woman?
No.
No?
Yeah. So what is the correct answer here?
A.
A.
Yeah, A is the correct option here. It's also referred to as early fetal demise. All the other options are not true. Question 72 says, in threatened miscarriage, A, patient almost always complain of severe abdominal pain. B, patients are hemodynamically unstable. C, bed rest and sedation have no place in the management. D, severe vaginitis is a differential. So what do
D.
you think? Sorry, B or D? What did you say?
D. D.
D?
Yeah.
Yeah, so you can have severe vaginitis can be a differential. They do not have, it is not that very severe abdominal pain as per se, and they are not they are hemodynamically stable. And of course, bed rest and sedation has a place in its management. Question 23. Pathograph A serves as an early warning sign. B, it is a graphic recording of all the events of labor. C, effective in preventing prolonged labor. C, all are correct. So what do you think?
B.
Yes. B.
Yeah, D, everything is correct.
Yes.
All these options are correct. Question 74. Principles of partograph. Active phase should not last more than 12 hours. True or false? Active phase of labor. Should it last more than 12 hours?
It should not.
Yes. Then B, active phase commences at 4 centimeters cervical dilatation.
True.
True or false?
True. True.
C, the rate of cervical dilatation at active phase should be slower than 1 centimeter per hour. Should it be
False.
slower? So that is false. Then D, vaginal examination should be performed as infrequent as it is compatible with safe practice. True or false?
True.
Yeah. So what is the correct answer?
B.
You said, what did you say is the correct answer?
D.
So C is the only answer that we said is false. So C is the only option that is false here.
Yes.
Question 75. Challenges with the use of partograph. A, poor knowledge of the partograph. Is it true or false? Is it a challenge or not?
It is.
Then B, manpower problems. Is it a challenge or not? Imagine having a labor ward
It is.
with 30 beds and then you have 3 nurses on duty. Is it a manpower problem or not?
Yes, it is.
Then C, use in breech labor.
Yes.
It is a challenge. Then D,
It is
abundance of partograph in health facilities. Of course,
No.
if you go to the level, you get more than 1,000 copies of a photograph. That is not a challenge. So D is the answer here. Then question 76. Fetal indications for cesarean section. Which of this is not a fetal indication? A, fetal macrosomia. Is it a fetal indication?
Yes.
Yes.
Fetal distress. Is it a fetal indication?
Yes.
Failed
Fetal
vacuum.
distress in the first place.
Yes. Failed vacuum or forceps. Is it a fetal indication?
No.
It's a maternal indication, right?
Yes.
Then D, face presentation. Is it
Yes.
fetal or maternal? So which of this
Fetal.
is odd?
Fetal.
Which is the odd option?
C.
Yeah, so
C.
C is the odd option here. Failed vacuum, because it is a maternal indication, not a fetal indication. So this type of questions are very tricky. Very, very tricky. You might even say, there is no answer in this question. So sometimes you just have to think twice. Which is not a component of ANC? A, pre-pregnancy counseling. Is it a component? preconceptional care. Is it a component of ANC, antenatal care?
No.
No.
Really?
Yeah, it is.
Yeah. Ideally, antenatal care starts with preconceptional counseling, even before you get pregnant. When the couple decide that, okay, they are ready to get pregnant, it starts with preconceptional care, and that should be at least 3 months prior to when you intend to take in. But of course, that is for people who plan their pregnancy. Of course, in this part of the world, we know it is always an unplanned pregnancy. It's rarely will you see a patient that will tell you, this pregnancy was planned. So, but it is a part of antenatal care. B, history taken. Is history taken a component?
Yes.
Yes.
Booking examinations. The examinations that you do at the first contact. Are they a part?
Yes.
Yes.
Postnatal classes. Is it a part of ANC?
No.
No.
Then E, planning of delivery.
Yes.
Yes.
So which is component?
D.
Postnatal
Postnatal classes.
Yes, so D is the only answer that is not a component of ANC. So always remember that there is preconceptional counseling. It is a component. Then 78. Suppose Sarah, for her scheduled ANC visit at 34 weeks of her pregnancy, you discover that her blood pressure is 120/60. She has mildly pale conjunctiva. What do these signs suggest? What does the mildly pale conjunctiva suggest? Come on, let's quickly finish these questions. We have like 18 more questions, 12 more questions to go. Or is it 18? 22. So let's try and finish them. So that maybe when you are refreshed, we can take patograph. If not today, maybe tomorrow. But let's continue. Let's try and finish the MCQs. So what does conjunctival pallor suggest?
Anemia.
Anemia.
Yes, and what action will you take? Will you give her magnesium, hematinics? Will you transfuse her, or will you give her multivitamins?
Hematinics.
Yes, so you give her hematinics. 79. The most common site of ectopic pregnancy is, let's see if you remember, because we answered
Axillary
this.
portion.
Yes, we said the ampullary portion of the fallopian tube is the commonest site for ectopic pregnancy. It accounts for 80% of all ectopic pregnancies. Then in the isthmus, you have 12%. At the fimbrial end, you can have 5%. Then at the interstitium, it's 2%. Then abdominal is 1.4%. Then of course, other sites, ovarian, cervical, less than 0.2%. So the commonest is the ampullary portion. 80, incorrect among the following is combined hormonal contraceptives may cause excessive weight gain. True or false?
True.
We answered this. B, high dose OCPs are associated with insulin antagonistic property.
True.
Yeah. Then combined oral contraceptives can be given in women with history of myocardial infarction.
False.
No.
Then D, low dose OCPs do not appreciably increase risk of clinically significant hypertension. Yeah, so C is the correct answer. We answered this already. We answered this as well, but let's repeat it. Oral contraceptives increase risk of all except which one?
Ovarian.
Yes.
Ovarian.
Ovarian.
Yeah, it's ovarian cancer. All except one is recommended for use in emergency contraception. We answered this as well. So which one is not an emergency contraceptive? We even answered it during the picture test as well. Which one?
C.
C. Yeah, selective estrogen receptor modulators. They are the only ones that cannot be used as an emergency contraceptive. I'm coming. Let me try and plug the charge and then we'll continue.
Okay.
Okay, let's continue. So question 83. All of the following are contraceptive implants except B. Of course, we've answered this one also. So which one? B.
B.
Yes, it's an injectable, not an implant. Then 84. Regarding preeclampsia, A, it occurs in 5% of pregnancies. Its incidence is reduced by use of low-dose aspirin. C, it occurs more frequently in diabetics. And then D, it is a multi-organ disease process which may cause intrauterine fetal growth retardation. E, edema is essential for diagnosis. So what do you think? What do you think is the answer here?
E the answer.
What?
E the answer.
E?
Yes, I think it's the answer.
Is edema still essential for diagnosis?
It's not essential because when there is high blood pressure, proteinuria, I think it's enough to diagnose the preeclampsia.
Yes. So it is not essential for diagnosis.
Yes.
At least we know this one is false. Is it more frequent? Is it more frequently seen in diabetics?
Edema?
No. the preeclampsia, is it seen most common? Is it seen more frequently in diabetic women?
No.
No, it's not frequently in diabetes.
Does it affect up to 5% of pregnancies?
Yes.
No.
So support your answers. Someone said no. Someone said yes. Who said it complicates up to 5%? Why are you suddenly quiet now? When you have your answer, you should be sure of your answer. You should be ready to back up your answer. You have not said anything.
It occurs in more than 5%.
Well, so it occurs in 5 to 8% of all pregnancies. So 5% is still within the range. So A is true. B, its incidence is reduced by use of low-dose aspirin. Yeah, you can prevent by giving low-dose aspirin in people with family history of preeclampsia. And you start giving them aspirin in second trimester. It occurs more commonly in diabetics. Well, this is not true. This is false. It occurs more frequently. Okay, more frequently in diabetics. Yes. Certain risk factors that can put the woman at risk of preeclampsia include medical conditions like hypertension, diabetes, chronic renal disease. So this is also true. Then E, edema is essential for diagnosis. It is not essential for diagnosis, actually. It is not true. Because initially you need edema to diagnose preeclampsia, but now it is not an essential for the diagnosis. And then D says it is a multi-organ disease, which may cause intrauterine fetal growth retardation. Yes, it is a multisystemic disease, and it can cause intrauterine fetal growth retardation. So E is the odd answer here. Is it clear?
Yes. Yes, it's clear.
A primigravida attends the antenatal clinic for her booking appointment. Her sister developed severe preeclampsia at 30 weeks gestation, leading to a preterm delivery. Her clinician plans to perform tests for the prediction of preeclampsia and plan her management. Which of the following tests is or are good predictors for the occurrence of preeclampsia? A, blood pressure measurement at booking. B, serum uric acid. C, estimation after 24-hour proteinuria. Regular measurements of BP. Measuring placental growth factor. Then test for alpha-fetoprotein. So which one is a good predictor for occurrence of preeclampsia? Which of these investigations will you use?
I think C.
Yes. So you do a 24-hour proteinuria and then you Ask for regular measurements of BP. So C is the correct answer. Then 86. Regarding drugs used to control the blood pressure in pregnancy. A. Methyl dopa is usually used for long-term treatment. True or false?
True.
Yeah, it is the safest antihypertensive used in pregnancy. So this is true. B. Labetalol can be given intravenously. True or false? Is there IV labetalol?
No.
ACE inhibitors are safe to use.
False.
Then D. Increments of hydralazine should be given every 5 minutes for rapid control of blood pressure. Is it
False.
every 5? It's 30 minutes. Glyceryl trinitrate is commonly used. This is false. So the only correct option here is A. Methyl dopa is usually used for long-term treatment of blood pressure, high blood pressure. $80, $90, $50, $100. What is the average blood loss?
80.
50. C.
Yes, it's 50. It's an average of 50.
Yes.
So which of this is not an assisted reproduction technique? ZIFT, GIFT, IVF, and ET, artificial insemination.
D.
Which one?
Artificial insemination.
Yes, artificial insemination is the only odd one. All these ones occur outside the body. Artificial insemination, only the sperm is being transferred into the reproductive tract of the lady. But all these ones is the zygote that gets transferred. Then 89. Pick the correct option regarding a blighted ovum. A gestational sac seen on ultrasound scan more than 17 millimeters without an embryo is diagnostic of blighted ovum. True or false? Does this describe a blighted ovum or not?
Should be more than 20.
Okay, let's look at the other options. Then B, it is synonymous with vanishing twin. Is it the same thing with vanishing twin?
No.
Fetal heart can be seen before it becomes absorbed.
No.
So, and then D says all are correct. So which one is the correct option? So this leaves us with option A. Sometimes you just have to strike out the other options if you are not sure of an option. You know that the fetal heart does not get seen in a blighted ovum. And you know it is not the same as vanishing twin. Of course, all these two are not correct, so all of them cannot be correct. So that leaves you with option A as the answer. So question 90, features of missed abortion excludes which of the following? A, regression of pregnancy symptoms. B, milk secretion may start especially in the second trimester. Fetal movement may not be felt or seizures. D, fundal height usually matches the gestational age. So which of this is the odd option in a missed abortion? Regression of pregnancy symptoms, is this true or false?
It's true.
Milk secretion may start, especially in the second trimester, if the pregnancy has reached the second trimester.
No, not correct.
Why do you think? Why do you say it's not correct? Question: assuming we are not sure of this, fetal movements may not be felt or it ceases. Is this correct or false? If she had a missed abortion, will she continue feeling the fetal movement?
Yeah, it is true.
Then D, fundal height usually matches the gestational age.
False.
False.
So that leaves us with option B. That leaves us to figure out whether option B is a true or a false. So actually, especially when the pregnancy has reached second trimester, she might start producing milk. And this is why sometimes when women have miscarriage, they start lactating, and you have to ask them to go back to reduce the size of their bra, and then you give, sometimes if it is much, then you have to prescribe drug for them to stop the lactation. So B is true as well. So the only option here that is false is actually D. Clear?
Yes.
Question 91. Which of this is not a cause of miscarriage? A, severe malnutrition. Is it a cause of miscarriage?
Yes.
Yes.
Uterine anomalies.
Yes.
Antiphospholipid syndrome.
Yes.
Yes.
None of the above.
Yes.
So none of the above is the answer. All the options are causes of miscarriage. Question 92. Which of this structure is not at risk of injury in a patient with obstructed labor? Is the anterior vaginal wall at risk when the woman is having an obstructed labor?
Yes.
No.
Mhm.
So what happens in vesicovaginal fistula? Is it not the vaginal wall and the bladder wall?
Yes.
Yes.
So the vaginal walls are at risk. The anterior vaginal wall, the lateral vaginal wall, they are all at risk. Uterine fundus, is it at risk?
No.
Why is it not at risk? Because when the woman is in labor, the head is already down, so there is not much pressure at the fundus of the uterus. It's more or less close to being empty. So it has, even if there is risk, the risk is very low. Then the bladder, of course, the bladder is at risk because the major problem you want to prevent in obstructed labor is occurrence of vesicovaginal fistula, which is an abnormal connection between the bladder wall and the vagina. So of course, C is the only option here that is not at risk. Then the 3, in the post-operative management of VVF, A, adequate hydration is important. True or false?
True.
True.
Adequate antibiotics is needed.
True.
Then C, ensure analgesics.
True.
True.
D, all are correct.
Yes.
Yeah, all of these options are actually correct. 94. Causes, all of these are causes of VVF except A, radiation, B, caustic salts, C, congenital, D, none of the above. Which of this is not a cause of VVF?
None of the above.
Yes, all of the above can cause VVF. So question 95, about the anatomy of the pelvis. A, the uterus is supported by the levator ani muscles, microrods, ligaments, and the anteparted position of the uterus. True or false? Of course, this is true. The uterus is supported by the levator ani muscles. They form the pelvic floor. B, levator ani muscles form the pelvic roof. Is it the roof or the floor?
No.
Floor.
The levator ani muscles are not the pubococcygeus muscle, iliococcygeus muscles, and ischio-coccygeus. Of course, these are the muscles. So just look out for that knot. Please excuse me.
How many questions are left? We had number what?
5. 95.
95.
Okay, there are 5 more questions.
Yes.
Okay. So we are going to send the slides. Then you will complete the other questions that are remaining. It's already 6:30 for today. I'll allow all of you to go and rest so that tomorrow we are going to be fresh. But from what I'm seeing now, we still have so many MCQs unanswered. We have pediatrics MCQs, pediatric picture tests. We've not done pathograph, surgery MCQs, surgery picture tests, instruments, images, counseling, level of preventions, medicine MCQs, medicine picture tests. So it seems we are still going to prolong our online class. So most likely tomorrow we are still going to take the online class. As I told you at the beginning of this session, the MCQs are the most important part of these exams. So it's good for us to answer as many as possible. Then before we come and demonstrate the physical examinations, then the rehearsal. We are going to have multiple, we can use 2 days for the rehearsal and the OSCEs. Okay, but I think it's better we complete all the MCQ discussions and you can revisit all what we have discussed for revision, especially when you are tired and exhausted. So we are going to stop here for today, and tomorrow we are going to continue. So inshallah, by tomorrow we are going to complete the remaining of our MCQs that are left. So if you have any questions, you can ask or clarification. Any question? Any clarifications? Okay, I believe there is none. So we'll call it a day. You go and have a very good rest today so that you wake up all fresh tomorrow and we'll continue. So thank you, everybody, and good night all.
Thank you, doctor.
Information
Thank you.
You are welcome. Any other information will be uploaded
Thank you, sir.
on the WhatsApp group.
Thank you, sir, very much.